Our next speaker is Dr. Anand Parthasarthy, a very senior surgeon, and he rarely needs an introduction. I would like to invite you for your talk on the intraoperative OCT. Over to you, Dr. Anand.
Enjoying this session a lot. My slides are visible.
Your slides
are visible. Make it full screen, sir.
Yeah.
So I've been asked to speak on See Closer, Go Deeper. Just a couple of hacks of intraoperative OCT for corneal surgery, and it's been a very good additional modality for intraoperative visualization, and it really helps across almost all endothelial keratoplasty, DMEC, dissect, SLET, DM detachments, and of course DALK dissections. And I'll just touch upon some of them as we go along. I think what is probably the best and most important thing is that you get real-time images. It is continuous, and the present OCT, the Zeiss which I have experience with, has both horizontal, vertical, and of course a raster pattern, which actually helps multiple times. So you don't really have to move the microscope multiple areas. Now, this is a hack which I realized when we want to really use the cornea, and this was the OT where I had two patients, one for DALK, one for ultra-thin dissect, and I had to make sure that I did the dissection perfectly so we have enough cornea for the keratoconus. Now, this is a 350 micron blade, so I thought, peripheral thickness being 600, I went a couple of times, I thought I'll be about 400, and I started the dissection. And you can make out the depth. Sometimes what you get on the blade is sometimes not accurate. We are hardly 50%, not even 50% of it. And once I started the dissection, I saw it on the intraoperative OCT. I realized that our dissection was less than 50%. So you have to be careful with a lot of these guarded depth knives. You may not really get them what they say. So also important to note that in edematous corneas, you probably need to overcorrect by about at least 10 to 15% beyond the depth that you intend to go. And you can make out the dissection. Now it's hardly about 50%. So I decided to go back again, re-deepen it with the same knife, and then attempted to go. I thought now I'm probably about 80%. So that is the perception as a surgeon. But when I restarted the dissection, saw it on the microscope, I realized I was about 60%. You can make out on the intraoperative OCT, there are two cuts. The first is about 50%, the second is about maybe 60, 65%. And then we decided to go deeper because I need at least about 80%, 90% of the anterior stroma for a keratoconus patient. So we finally went deeper again, and then I started the dissection. Now you can make out that you got three levels of dissection: the first, second, and the third. Third is the longer one, if you can make out the OCT. So this is what I wanted. And if you are very careful, and this I feel is the real advantage, that you can do a very considered and conscious dissection. And once you go across, you can make out that the depth I'm actually now getting almost at about 80%. And remember, these corneas post-op will thin. So you have about 80% of anterior stroma for the keratoconus, and you have 20% of the posterior stroma for the ultra-thin dissect. And if you're very careful, even people who don't have a proper automated keratome, you can actually go ahead and get a very, very clean, uniform dissection across all planes. And you can, as you take this using multiple dissectors across, you can make out a very, very good dissection plane across all levels. So this really helps if you're doing it consciously across even the other side. Now I'm on the other part of the cornea. You can make out the dissection is actually quite good. See, the depth is very good. I'm actually quite happy. So we actually went ahead with what we planned, and we didn't have a surprise when we finally finished the dissection. You can make out, just to show the depth of the dissection, actually quite good. The second is this patient in which we did a FEMTO DALK. Now this is the recipient, and just to show that the step ladder pattern, because in FEMTO DALK, this is FEMTO assisted DALK, wherein you do the anterior, this is a keratoconus, so you can actually make out the very good step pattern. And this we oversized about 0.2 for patients with keratoconus, and this is the step pattern, very, very nice. because the tricky part in femtosecond, remember, is sometimes you don't actually get the bubble as you would really want. So you peel off this. We decided to do a manual dissection because we were not getting a separation of the posterior stroma. I tried an air emphysema, I was not getting it. Then we decided to basically go ahead with a dissection, a manual dissection. You can make out that I've not actually got a complete dissection, maybe about 80–90%. So I decided that I don't want to take a chance with just air bubble injection. We do a manual dissection, and it is multiple layers, very, very gradually. As you go deeper, you can actually make out that if you are conscious about what you want to do and what you aim to do, you can get these corneas to almost about 90%. This is the end of dissection. You can see the lump of the stroma, and we are at about 80%, which I feel in a patient with keratoconus will get as good results as getting a big bubble DALK, because we've done studies on that. The manual technique actually works quite well. This is the end of dissection. You can make out we are almost about in the central visual part, which is important. We are almost about 85–90%. And the peripheral dissection is done. This for the donor also, just to make sure you got the step correct. This is important before you remove it out of the artificial anterior chamber and then basically place it. You can put trypan blue to remove the descendants and then place it right. The fit is actually quite good, and it's almost like a lock and key fit. And these patients actually do quite well post-op. You just need maybe about 8 sutures to finish these surgeries. This is a video from Dr. Namrata, just to show that this works quite well for DMEC as well, especially for removal of the donor. And once you inject it, and probably in DMEC, the application of the intraoperative OCT has been quite significant, just to show the scrolls which show the orientation of the corneas. Now, this is also important, especially in DMEC assisted for DSEC, as well, to make sure that you remove the water clefts across the position of once you insert the, because we feel that on anterior chamber, when you actually visualize it, and if you have slightly bad corneas where you do not have good visualization, you can make out these water clefts which need to be eliminated. So I usually do paracentesis, basically full thickness corneal incisions on the recipient stroma, and you can actually, even when you're injecting air, you can see that the graft actually moves. So you got to make sure that all these water clefts are clear on table. So you might take 5–10 minutes extra. In desmetopexy, important, especially post-cataract DM detachments, you can still get peripheral detachments. These need to be removed. A hack which I learned from Dr. Namra is to put a bit of Helon or use the cotton bud to make sure when you remove the needle, the AC doesn't shallow, because that itself can cause a detachment again. In SLET, important to know the depth of this dissection, especially in terms of whether the stroma is actually involved quite deeply or not. In type 1 bubble DALK, as you remove the bubble, you will see that the descendants actually gradually comes up. This is a very nice indication that you've got the big bubble if you're not using the small bubble technique. This is just, I think big bubble I've already mentioned. And in interest of time, I will just conclude by saying that the intraoperative OCT is a very useful addition. It is very effective in tricky situation, acts like a third eye. It is an important part in the armamentarium of corneal surgeons, and usually helps to improve optimal outcomes post-surgery. Thank you so much for your attention. Thanks, Arvind, and thanks, Somashila.
Thank you, Dr. Anand. Excellent summarization.